Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Hello and welcome back to the Sit and Stay podcast, brought to you by RipsyTech. I am one of your hosts, RipsyTech's very own product manager, Parker Anderson, and as always, I am joined by the illustrious founder and CEO of RipsyTech, Tom Tarshis. Hey, Tom.
Infermos tuere, Parker. Hey, Parker.
Infermos tuere. That's our new favorite Latin phrase that we made up. What does it mean, Tom?
Well, we're hoping it means fight for those who need to be fought for.
Like fight for the vulnerable or something like that. Yes.
Right.
That's right. Oh, I was in the room when we came up with that. So we did a lot of back and forth and workshopping until we landed on something that we liked. Not necessarily something that's going straight into like any marketing copy or anywhere. It's just kind of like our own internal fun mantra to say and remind ourselves, it's our new legion that we're starting or something.
Yeah, just putting a name to, as you know, as the years go by and we get a little. As with every mental health practice, RipsyTech also is a startup company, and you sort of set out along certain paths and see what happens over time, and you learn from it and pivot. And we have just the philosophy around patient care and other aspects that we've sort of fought. The vibe is true to what we're doing, and I probably there'll be more. I don't know if it's worth a podcast, but we are sort of rebranding a little bit here coming up, and that might be interesting for people to hear about. But that will be up to our operations person, Parker Anderson.
Thanks. Now you're giving me ideas, like when you look at the MGM logo with the lion, it says, Ars Gratia Artis, and that means art for art's sake. So I don't know, you're making me think of like, can I come up with some kind of RipsyTech emblem or something like that, or I could just kind of sneak that in there. That'd be a fun little project.
I like it.
Well, thank you. All right. Well, anyway, before we dive in, just wanted to quickly shout out that we created a How to Start a Private Practice course, getting at that idea of what we're all about, of helping people start practices that want to start practices, helping providers hit their highest potential while getting practical guidance that is proven from yourself, as somebody who knows a lot about this topic. So go to ripsytech.com/practice if you would like to check out our How to Start a Private Practice course. We think if you are on the fence about starting a practice, we're hoping to push you to the other side of the fence with confidence. All of that said, let's dive into today's podcast. So last time we got into some big topics around insurance companies and how they're making mental health care harder to provide and harder to access. So we talked a lot about documentation requirements that make psychiatrists justify standard therapy over and over again. That was a pretty eye-opening topic. And then we also talked about misleading out-of-network explanations of benefits that can leave patients confused about what they're actually owing to the insurance company, to you, all of that. But the big theme overall was that these are not really just annoying paperwork issues. They may be intentional ways of creating friction for providers so that they might decide, you know what, I'm not going to take insurance, or maybe I'm not going to negotiate for a better rate, or something, anything to really benefit the insurance companies. And patients likely are the ones who end up having to pay for it. So Today we're going to pick up where we left off because, Tom, I know you have brought more stories to the table from the front lines, the vanguard, so to speak, and the Enfermos Tuere vanguard. And I know you also wanted to talk about what happens when you actually try to fight for, single case agreements, for example. That was something that you talked about at the end of the episode. So I will leave it to you to kind of pick up where you left off, wherever you want to start.
Parker, I'm at the stage in my life where when you consistently sort of try to be reasonable or not push too hard, and for years you see patients and providers taken advantage of, at some point, I think the gloves need to come off and you need to just push on every level. Mm-hmm. And so that means legislation, that means the press, that means calling out more stories, that means rallying people to the cause, and it's time to do that a little bit. So, I'm glad that enough other people are outraged by this memo that was sent, and we'll be taking it up as a group. And I hope that, maybe it's something that there can be a quick legislative push on, and it's sort of withdrawn. Can we get enough buzz going through the legislature? Do we need to bring the media in? Whatever we need to do to fight for our patients. Just on, the ridiculousness of, I do think sometimes insurance companies see this field as so many people don't take insurance. Let's go ahead and see if we can make no one take insurance. And then, hey, no one's using our services and it's higher profits. We had research showing that when psychiatrists are allowed to do therapy, you're able to get kids off medication and they get better sooner, and it actually costs less money. Imagine that. Giving good care there's cost savings. It's a hard financial argument to sell to companies that are publicly traded because they're most concerned with the next quarter shareholder report. So those savings, if they don't come within the next 3 to 12 months, it is lower priority. And because so many people's jobs switch insurance providers year over year, they're not really you can't even make the argument with them that, hey, look, over 5 years, this is going to save you money, because they'll say, well, this is unlikely to be our patient in 5 years, so we don't really care about that. So what saves us money for the next quarterly financial report?
All right. Well, okay. Hold the phone. I'm a little. I think I'm a little embarrassed to admit that I'm maybe just now learning this. Are health insurance companies publicly traded companies? Or
Mr.
they
Anderson.
can be. I already knew it was bad, with the health insurance companies, but you just kind of you really just blew my mind. I don't know. That feels unethical. It feels illegal. I gotta Google it now.
Yeah, well, and there's a great little clip of a physician Congress, I think congressman or senator. The insurance company executives had to have to testify often. And there's a good clip of him, tearing them, going into them. And I can send you the link later to watch. But Parker, just to, PG&E, utilities companies can be publicly traded. Monopolistic utilities companies, that is our world.
Yeah, it just feels like that shouldn't extend to certain things. We don't need the capitalistic competition number go up aspect of everything. But I'm going to stop before I get on my own soapbox.
There you go. Well, you are further from Canada now that you're living in Georgia instead of Virginia. So
that is correct.
So that's sort of the update on this, try to make it very difficult for psychiatrists to get reimbursed for or provide psychotherapy. So we'll leave that piece to the side. I did want to jump to sort of a very ridiculous story. The most extreme fight to get a single case agreement I've ever experienced in the last 20 years. And I was happy to share it because I felt like we had achieved a positive outcome finally when we were filming our last podcast. But I have come to find out that the fight is not over, and it will be part of the story.
Now, does this tie back to the single case agreement that we talked about back in November around Thanksgiving time, or is this a complete? Oh well, I imagine it's got to be a completely different case if it's 5 or 6 months later. But
yeah, what do you remember about that single case agreement or that discussion?
Gosh, I believe it was that we had you had to wait a few days. Office was closed. Thanksgiving took too long to get the clinical information, and then I don't know, maybe 5 phone calls later, something like that.
Yeah, and that was actually something that was via RipsyTech for one of our clients, with the sort of ridiculous response time that ultimately that was why we got the single case agreement. This is a story through our nonprofit practice, and I will say, I think we've talked about this a little bit potentially, Parker, but let me know if it rings a bell that every insurance company, a lot of them have between 100 to 500 different plans within the insurance company. And hey, if you're a big company like Google or Apple or Oracle, your employees are probably going to get one of those plans that's better than that's in the top 5 instead of in the bottom 5. And a lot of the success in getting single case agreements, it's clear it comes from, are you at a big employer who sort of is given better options for its employees, because that's a big contract for the insurance company. And so historically, a lot of our single case agreements have, we're in Silicon Valley, and there's a lot of big companies here. And if you're at the right entity, and it is a lot easier to sort of get the process rolling. And what I've realized recently with 2 cases over the past year is that there are these federal ERISA self-funded insurance plans. And this is a way for smaller businesses to save money on some insurance costs. And I believe if you sign up for, this is a plan offered through one of the big HR automated companies. And what people don't realize, though, about these plans is if you're giving up any state protections on insurance company mandates if you sign up for these federal level ERISA plans, which almost every state in the country has additional protections around what health insurers can and cannot do. And so it's a bit of I don't know about a scam, but sometimes people get these plans that they don't realize how lacking the plans can be because they're at this federal self-funded level. And I do have 2 cases where we haven't been able to get single case agreements, and they're both with these federal plans because slow response time, the insurer knows this, they just don't even respond, like sort of ridiculous things happening. And it's something that I actually need to educate myself a little bit more on, and we can maybe do a podcast on. But
so are these ERISA plans? They're not through one of the big major insurer companies. They're kind of their own separate thing.
Yeah. However, the major insurance companies do offer these ERISA plans, but they're not subject.
Okay.
And ERISA stands for Employee Retirement Income Security Act of 1974. So I'm not even sure how that is tied in. It's definitely called ERISA plans, but I'll educate myself on it and we'll talk about it. But it is clearly something that when the insurance company becomes administrators for these, you can have this plan, you can hire a big insurance company to use its provider list, but then they don't have to give you sort of the same protections afforded you by state level plans if you're a consumer. And in fact, you can't even report it if you don't report it to your state insurance board. It has to go to like the U.S. Department of Labor or something. So you can imagine that the extra complexities. And
so the ones that you have, are they the two that you mentioned, are they through major insurance companies or are they through companies that you've never heard of?
Those two are through the same major insurance company. And I'm going to actually talk about an employee who had a better plan than that through the same insurance company, and the saga we went through
for a single case agreement.
For the single case agreement. And
okay.
So here, as we've talked about, or we talk about in the private practice course, sometimes people change insurance plans at the end of the year, and if you're a clinic, it's unlikely that you accept all insurances. And unfortunately, despite reminders or telling people, be aware of making insurance changes, or here's the insurances we accept, or you agree to let us know right away if you're changing your insurances at you can ask our finance director. There's always chaos at the beginning of the year because people have changed insurance. We don't find out about it. The worst case scenario is it's with an insurance we don't accept. And so that was the case with this family. A parent and a child were both patients of ours for at least 6 months, and were making very good gains in care. But then insurance changed. We didn't even find out about it till maybe 10 days into January. And so immediately, the one extra thing about continuity of care matters. So getting a single case agreement with a current patient whose insurance changed, it gives you one extra argument with the insurance company. So that's nice. Mm-hmm. However, and it is an insurance company that we have many single case agreements with, which is another positive check mark. The concern, Parker, is that it is critical that the members have to institute the single case agreement.
Is that specific to these plans, or are you talking just in general as like
just in general?
Yeah.
So what happens is, they call the number on the back of their insurance card. They say, we need a single case agreement. The automatic first response is, oh yeah, sure, just tell the clinic to call us. And so the patient's like, oh great. But if you call the clinic, and this is true, if you call insurance, if you call and say, I want a single case agreement for this patient, they'll say, oh, okay, sure. You're calling us, so you'll accept the rates that we give you. So that's the problem with the clinic calling the insurance company. You take away your ability to negotiate rates.
I see.
So we have our handouts on this, and we educate families. No, they will tell you this, but you need to say, no, I need a care manager assigned to this. We need continuity of care. We need to get everything rolling and started. And you need to call the clinic in order to so we can be seen there. And so some people are better than that than others. And sometimes people being treated in the clinic might not be the best at getting this task accomplished. So this is where it's great to have some lawyers as patients in your clinics. No, but So if that and then the longer time goes on, just the more that's like check marks in the insurances category. But ultimately, yeah. So ultimately, this family, maybe pushing towards the end of January, did get in touch with someone and then had it so that the someone would be assigned to the case and they'd be able to like reach out to us. And yeah, I can even put together a very detailed timeline, but we'll just stay sort of in general timing for right now. Right. So ultimately, ultimately first there was pushback between no, here's some people that you can see. And they sent a list of 3 doctors that first of all violated you need to be within 15 miles or 30 minutes of the site.
Okay.
It's the Bay Area. There's high traffic. It's easy to do the Google Maps time estimation. However, like 2 of them then were not child psychiatrists. None of them had board certification. And it was this like,
whoa,
not that board that could be a whole other topic about the value of board certification. But in general,
yeah.
if you're a consumer, you want your kid to be seeing someone who's qualified and appropriate to see them.
Right. I mean, I have a child, and I would like for my child to be seen by the best.
Yeah, right. That's what everyone wants for their kids, right? In all aspects of life. So, so after helping the family manage this email pushback from the insurance company, ultimately they did, it got arranged for them to call us in order to do an appeal for services on behalf of the patient. So sometimes one phone call from the patient with a very good insurance plan, and then we get an email a few days later, and then you immediately get authorized for the coming year. And step 1 is just getting the authorization. Step 2 is fighting about the appropriate reimbursement rates. So for this family, the insurance was pushing back on them that no, we have providers through email. It took a couple of weeks to even get it to the place where, okay, we see that the providers we sent you don't actually meet these guidelines. But instead of then authorizing the care, they said, well, it has to go to an appeal status, level 1 appeal. And this is where then there's going to be a doc-to-doc to discuss the case and the care, and that's what's going to need to happen to get the authorization. Which is fine. Like, again, it's this plan issue that usually we don't need to do a doc-to-doc at all, and like, here's your 999 visits authorized for the year, and then you get to the negotiation phase. But for this family, it got to the place where, okay, we need to do the appeal, and then the calls got scheduled. Keeping up so far? Here's where the fun starts.
I am keeping up with so far. I feel like once you brought up the doc, I might be privy to how this ends. You might have told me already. Let's hear it.
That is fair. Yeah, and so we have a new. If you're a new, not even if you're a new psychiatrist, but if you've never done these calls or fought with insurance companies on behalf of your patients, they can be quite disconcerting, and it's not even just people calling to like present the case and talk about best care with a colleague. It's like a battle. Like you're fighting a peer to try on behalf of your patients, and
right.
There's it is reasonable to have other child psychiatrists available to review that proper care is being provided, but that's not really there's been 60 Minutes on this topic, and they're like people nicknamed Dr. Denial and all this other stuff. Unfortunately, the phone call, the doctor kind of bullied my new psychiatrist, and instead of like even really talking about the case, they said, look, there's all these providers on this list, and no, the rule is 30 miles or an hour. A blatant, either just blatantly lying or not knowing the California laws around distance and time requirements, and then said, so I'm going to go ahead and deny this, and sort of that was the end of the phone call. And yeah, so and
I'm sure the insurance company loves that doctor.
And unfortunately, I didn't. They always mumble their name, and I always be like, "What is your name again?" And then I didn't prep my new psychiatrist to like say, "What is your name?" So that we can have a way to know who it was. And on the denial letter, it says sincerely, medical director, and it just puts their initials. Like, you're so embarrassed, like you won't put your name on the denial letter. Yeah, probably because people will like find you, and anyway, there's something wrong when as a physician you're not going to like sign your name to a decision you're making. Like, what is that?
Right.
Anyway, my call was the next day. So I was already agitated.
So are you like second level appeal call?
Oh, good question. Sorry, and I didn't make this clear, but he sees the caregiver in the family, and I see the kid. So he was doing the like single case agreement appeal for the parent, and I'm doing it for the kid.
Gotcha. Okay.
So quickly,
because turnaround time of a single day for a second appeal would be unheard of.
Correct. And so then I was the next day, and then, I immediately got the name of the person, and then I quickly started ranting, that, and pretty quickly the doctor, yielded, because I was going off on like, by now it's March, we haven't been able to see the family since January. That people are collapsing. All the progress we made is, falling back, and like you're like this is people whose lives were getting better, and because of this ridiculous process to continue care, you're seeing suffering come back on, and that is very wrong. So, but I, been doing this many years and was able to push back and, explain the law around drive times, which this doctor immediately then also tried to do. And in my mind, I'm like, dude, do the clinical care piece. Why are you being the cop? Like, how is that the doctor's role to like say, oh, well, this is 15, like that shouldn't be the role of the physician. You should be there to talk about the case and the clinical care. Like, go get a side job as a security guard. I don't know. But anyway, my years in the field, I quickly got the approval for the single case agreement. And then I'm like, I tried to push, who was the doctor who called my staff yesterday? He said he had no way of knowing. I think that was true. I tried calling back the scheduling team to get the doctor's name, apologizing for being angry at the scheduler and knowing she has nothing to do with anything. She was able to send an email. She couldn't even get a supervisor for me to talk to.
Oh man.
So anyway, so then, yeah. So
they thrive on the shadows. Like, it's okay.
Yeah.
Phantom doctor.
But we were able to do a second level appeal. So this time I called back, still in rage mode, saying sort of, your doctor bullied my clinician. I am going to be doing the phone call for the second level appeal. This needs to be urgent. There is language you can do to make them call you within 48 hours. So we got the second level appeal call scheduled. And this was around mid-March now. And then that, that doctor, in the meantime, the 39-page document with all the providers that the person could see arrived. And so, plugging it into AI, of the 60 providers there, 10 were actually within the distance that was allowed. And then of those 10, 4 of them don't even work in California. So Parker, this is the ghost networks that if you go and look up, sure, look at this, 100 people are here, but it's called Ghost Network for a reason. It's all those 10 that were within the distance, none of them were actually real people with openings to actually see anyone. Right. So
yeah, I mean, I don't think anytime I've talked to my own insurance company to figure out who are the available providers near me, and I don't think that list has ever helped me, not once. No, yeah, never, because it's a ridiculously long list, and you look up people. I remember, I think I reached out to a few, and no, yeah, just I'm not available. I'm not taking patients. Yada 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 yada, and it's like the fact that can all fall onto the patient or the patient's family who's trying to look for care. It's like, oh yeah, cool. Like, thanks for wasting my time. Anyway, yeah. So Ghost Network bad. What happened next?
Yeah, and one of the other pieces, you have to offer in-person services. And so, a lot of people are knocked out because they're really telehealth only, and even though they're showing up on this in-person service list.
Oh my gosh! Yeah. Okay.
Yeah, and so, so I was prepped, with here's all the patients on the list, and then so right away, a different doctor called, a new doctor, and then. Immediately was going into the distance thing, and I was like, just don't, raging, don't even get me started. And I was feeling aggressive and annoyed from the beginning. And then he pulled up a name of, no, there's this provider right here, a few miles away. So then while I'm sort of still in a rant process, and I Googled this person whose name he gave me, and it's not even a psychiatrist, it's like an internal medicine doctor. So I'm like, here's what this family's been going through, here's the suffering, here's this denial that happened. Oh, and by the way, are you at your computer? That name you just gave me, it's not even a psychiatrist. And then he typed it in, and he saw. And then I was out of control on my rant and monologue. And then he's like, he did cut me off, and he's like, hey, and I was sort of and then you guys get on there and you give these networks, and then you give these people, and they're not even real, and you're gotta be kidding me that you're not going to let this patient be seen. Do you see the ridiculousness of, and then he sort of yielded and what, yeah, you're right. I'm going to give the authorization. And then, and then was very apologetic in nature, but, I don't know, too little, too late. But so and then Parker, I think I talked to you after, it was months of fighting. I don't even know how many hours of my time I gave this, but it becomes about justice. Mm-hmm. The asterisk that I didn't even realize till a week ago. So this battle is not over, because every other single case agreement, as I alluded to, the foreshadowing in this podcast episode was we get the 999 authorized visits, and that has never been an issue.
Yeah.
When the authorization came, and actually as I was inputting it into the EHR, I was like, wait a minute. There's only 14 visits authorized for the year.
Oh, that's crazy.
This is a weekly therapy patient. This is not a simple once a month. So I called last week, but now it's looking like I need to do like another appeal. And here's what's going to happen, Parker. They're going to say, oh, no, well, you can't start it till you run out of authorized visits.
Yep.
Well, so,
no, I'm familiar with that one. That's how it worked in IOP.
So I'm going to, push back hard. I will pull the data that, hey, here's my 20 other single case agreements. They all have 999. What are you doing limiting them? And yeah, the battle is not over.
Now, are they allowed to, or will they attempt to make a justification for 14 versus 999 because of the payment, because of the insurance plan that this person is on? Like, are they allowed to state that as a reason, or is that just kind of like really the reason, but not the reason that they give?
Yeah, I don't think they're allowed to like state that. I think it's, there are patients who are stable that you can see once a month and,
Right.
14 visits but clearly from this patient and family who had been receiving actually twice weekly interventions, which was what was required to start getting care. And this was made, it's even as prepared as you can be, and with all my experience, it was still an issue because this has not been a problem over the past 2 years with this insurance for the number of authorized visits. And so, and then secondarily, they were supposed to backdate it, the authorization to January 1st, because there were the visits that first week of January that we want to get covered for the family. And they didn't do that either. So that is on my task list. Like at this point, if they don't backdate it, the family's okay with it. The family is very appreciative for the sort of efforts we're putting in, and but yeah, I like, there is the law in California that you can't have these ghost networks and that they're big fines, punishable, but there's no enforcement. So that's other legislation trying to get pushed through to have some enforcement.
Yeah, that's wild. That You're a good guy, Tom. Good guy.
just stubborn. Well, but Parker, like the crisis, right? There's a lot of talk and other things about socioeconomic disparity and other issues, but there is sort of mental health treatment disparity as well, and it's
Totally.
As more people stop taking insurance, that's just going to get worse and worse. So if you're only allowed sort of less than best practice telehealth care for your mental health issues, when someone who can pay the cash rates gets best treatment, that's not okay. And there are laws that say that that's not okay, but it gives us a fighting framework. Join our struggle.
Yeah. Okay. Well, so yeah, I guess keep us posted on what happens next. Maybe if some conclusion or resolve comes to this, you can talk about it in a future mental health business moment or something like that. Here's a quick word from Rye, our AI mental health practice advisor.
This is Rye, your AI mental health practice advisor. Practice owners often ask, what's a realistic mindset to have about profitability in your first year? A realistic mindset about profitability in your first year of private practice is patience. Initial expenses and building a consistent client base delay profits, so consistency and financial discipline matter more than speed. For more practice advice, ask me a question at RipsyTech.com.
Okay, Tom, run me through it.
Yeah, we've talked about my business license struggles often in Berkeley, and I think I maybe even talked about that the mayor's. I got some movement from the mayor's office.
Yep.
Similar to the previous story, that wasn't necessarily enough. However, because I had sent in my payment to get had to get the 2024 license, etc., so that you could do the 2025 and 2026. It went to their problems continued. Ultimately, I was able to like reach my contact again and explain what had happened. And then on Easter, which was a Sunday and a holiday, I got my electronic 2026 City of Berkeley business license. They didn't make me apply for the 3 years in tandem. And now we needed this critical piece of paper to do other social justice endeavors. And I could not believe that showed up. It was like the Easter Bunny went into the mailbox and is like, here is your surprise golden Easter egg. And
nice.
Those little victories
nice.
like keep you going.
That is nice. I'd love to hear it. All right, Tom, let's wrap up this episode here, I think. That's it for the Sit and Stay podcast this week, brought to you by RipsyTech. If you enjoyed the episode, we would love a rating or review wherever you are listening. And if you want to get in touch, email us at sitandstay@ripsytech.com. All right, Tom, I'll see you next time.
Thank you, Parker.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.